to get started. Thank you everybody for joining, and we'll have probably a few more people join. I am Caitlin Ragland. I am a PGY5 at UAB, so University of Alabama at Birmingham, and excited to have an adaptive session today sponsored by Varian. We have three panelists joining us today. Dr. Henke from Case Western Reserve. We have Dr. David Scher from UT Southwestern and Dr. Sampson from Washington University in St. Louis. So we'll have those three. We're going to have three kind of separate sessions here, some active poll questions. And we'll most likely just reserve questions for the end of each session, but we'll be happy to have discussions, and feel free to have write questions in the chat, and we'll see if we can address those with time. So thank you, and we'll be getting started here.
Thanks for having us, and thanks everybody who's joining on. I'm Lauren Henke. I treat GI cancers at University Hospitals Case Western, and so I'll of course be talking about abdominal cases for adaptive radiation. So starting with an initial presentation here that is probably one of the more straightforward things that we see in our oncology clinic, but can initially have some questions behind it. So a 58-year-old woman who presented with painless jaundice to the emergency department. Although we probably jump right to considerations like cancer, can also think about things like hepatitis, cholestatic jaundice from things like gallstones, although usually not painless, hemolytic causes, lymphoma, taking some more history. There's maybe a question of pain initially, but it turned out to not be so. She did have 20 pounds of weight loss, but it was in the context now of Ozempic, which is something that we're more often seeing in clinical context. So she got the initial laboratory workup coming in the door. Again, that question of pain initially, so they threw in lipase amylase, which were normal, no pancreatitis in the mix. Her CBC was unremarkable, and her complete metabolic panel was very notable for a total bilirubin of 11.6. And somebody got smart and threw in a CA19-9 at that time, which was elevated at 2,794. Next slide. So this finding of the elevated bilirubin then immediately prompted a CT abdomen pelvis, which showed a 3.4 centimeter pancreatic head mass. I think it's almost a little easier to appreciate it in the coronal slices here. You can see the celiac trifurcation, actually, especially in the coronal view, but it's in there on axial too, is actually completely encased by soft tissue. Which also is encasing the common hepatic artery. So the celiac artery and the common hepatic artery both encased past the GDI takeoff of from the common hepatic to become the proper. So this then prompted a little bit tighter look at her imaging with a pancreas protocol scan, which really showed the same things. Next. Of course, she had the bilirubin of 11.5 being the most urgent thing to deal with, and so that prompted an ERCP with stent placement to resolve that biliary occlusion. At the same time, which is often done in the same procedure if there's a known mass to go looking for, she had an EUS or endoscopic ultrasound with fine needle biopsy. Sometimes you'll see FNAs done as well. The biopsy tends to get a little bit better pathology specimen. And that showed grade 2 adenocarcinoma, consistent with a pancreatic ductal adenocarcinoma. And something that we're seeing checked on more and more cancers now is mismatch repair status. In this case, she was proficient, so intact. Next. And once her bilirubin, her biliary obstruction had been resolved, it's important to know that her CA19-9 a few days later had then gone down significantly. So something to keep in mind when you're working up a pancreas cancer like this is that CA19-9 is often elevated in the setting of biliary obstruction for benign reasons of that biliary obstruction. And so the immediately super elevated CA19-9 is from both the cancer and the biliary obstruction. So to get the kind of tumor marker value that you want to make sure that you check it once the biliary obstruction is resolved. Next. Okay, so as we're thinking about treatment, what anatomic factor, and hopefully this is a nice soft question to start with, determines resectability for surgery? So is it GI organ invasion? Is it nodal disease extent? Is it biliary tree involvement, or is it vascular involvement? Okay, so I don't know how many people answered, but so far 100% of people have gotten this right. So good, I gave you a good warm-up question. So really it's the vascular involvement that drives the resectability of a pancreas cancer. In this case, she had the celiac trifurcation encased. If that had been the only vascular involvement she had, she might have qualified for kind of a special surgery called an Appleby, but because her common hepatic was also encased past the GDA takeoff, she is immediately put into this category of locally advanced unresectable disease. Okay, so next. Yeah, it's that vascular involvement. So the plan for her treatment is usually in this scenario, we'll still start with neoadjuvant chemotherapy, typically done for 4 to 6 months. That's the same approach that's used actually in a borderline or sometimes in resectable patients as well, ahead of, in those cases, surgical considerations. But in this case, we do the lead-in chemotherapy with plan for subsequent ablative radiation as the definitive local therapy, assuming that as she gets restaged along the way, she remains localized and still unresectable. The way that we approach ablative radiation at our center is with adaptive radiation, daily adaptation. We use a CT-guided commercial platform, and we prescribe 50 gray and 5 fractions with an SIB for elective nodal coverage of 33 gray and 5 fractions. And we deliver this daily. There are centers that do every other day as well, and neither is right or wrong. Next. Okay, so just getting you a little sense of the anatomy that we're dealing with. Okay. So what do I mean when I'm talking about adaptive radiation in the setting of pancreas cancer? There are different reasons that adaptive radiation is used, and you might hear some of those different reasons from Dr. Scher and Dr. Sampson later. But in pancreas cancer for ablative radiation, we're usually doing daily adaptation with a response to organ at risk anatomy changes in mind more than anything else. And that's so that we can try to deliver ablative doses safely while maintaining the same strict organ at risk constraints each day and kind of keeping a lid on the toxicity risk. So we have a hypersite CBCT on our Ethos platform. We image and treat these patients at XL breath hold. That is the same for their initial simulation planning. And you can see here the initial plan, the turquoise color is the PTV. There's a red target in the background, which is the GTV. I'm showing you the high dose target here and not the ENI here. We'll go to the ENI in a moment. And you can see that, as always, that 50 gray isodose line is not touching those organs at risk, and that 33 gray line, which is our elective nodal prescription, but it also is our max dose constraint for OARs, is kind of kissing up next to the stomach and the duodenum, but not overlapping with them. So that's the original sim plan. Everything looks perfect, like always. However, then the patient actually comes in on day 1 of treatment. And this is what that simulation-based plan looked like when it was applied to her day of treatment anatomy. So you can see there have been little changes in her stomach filling, positioning. We're at the same cross-section of the tumor, so that's the same. But now, because of that duodenal and stomach positioning and filling, that 33 gray and even parts of the 50 gray isodose lines are overlapping with her stomach and duodenum, violating those constraints. So this is when we then, next slide. Oh, yeah, I'm showing you those isodose lines. There we are. Okay. With daily adaptation, we remake or re-optimize the daily treatment plan based on the daily organ at risk anatomy. So now you can see that those isodose lines that were overlapping with the stomach and the duodenum, they are no longer. They're pulled back out of those organs at risk, keeping that toxicity risk low and still maintaining good target coverage and not having to do things like use planning organ at risk volumes or PRVs, which kind of intentionally cut into target coverage to give protection volumes. So this is the way that we use CT-guided daily adaptive in our clinic for pancreas cancer, is really to adapt for organ at risk position and to maximize coverage and dose escalation at the same time. Okay, next slide. Giving a little bit closer look at the elective nodal coverage because I think this is relatively new for a lot of places. As recently as just a few years ago, ASTRO actually had a conditional recommendation against using elective nodal irradiation in pancreas SBRT. However, there have been a number of series, Johns Hopkins publishing several of them, Northwell as well, MCI, evaluating patterns of local failure after SBRT. And most often, these patterns of local failure are happening not just obviously at the gross tumor, but in these at-risk volumes, often referred to in the surgery literature as the triangle volume, which is more or less a zone around the celiac artery, the common hepatic, the groove between the aorta and the IVC, and extending down to the SMA. And so that has led to the recommendation published by Dr. Nina Sanford et al., if you want to click, in the last year in the Red Journal to cover elective nodal volumes, which start just caudad to the celiac artery, cover the celiac bifurcation, the common hepatic artery, over to that GDA takeoff, click again. Then down, there's that GDA coverage over the portal vein, down covering the SMA, and then extending all the way inferiorly, if you want to click one more time, to the first jejunal branches taking off from the SMA and SMV. So that's what we mean when we're talking about elective nodal radiation. It's a little bit different for tail tumors. I won't get into that. Our case is a head case here. But this atlas that's there in the citation is a great resource. Okay, next slide. So, which of the following is not a regional nodal site for a pancreas head cancer? Are periaortic nodes, aortocaval, peripancreatic, periceliac, or periportal nodes not technically a regional nodal site? This one's a little bit trickier. Okay, good. Do some teaching here. So periportal lymph nodes are technically still a regional nodal site. What's actually not, which is somewhat counterintuitive, I think, is these aortocaval nodes. So the nodes that are actually back behind the aorta in the groove between the IVC and the aorta, or technically retroperitoneal, those are actually technically metastatic nodes. Now, they often get encompassed by some of our treatment field, and if I had a patient, off trial that had a single node in that site, and it was right at the level of the tumor, I'd probably still treat them with ablative dosing, but that is technically a metastatic site. Okay, next slide. So why do we do ablative radiation? This seems like a lot of work to do a daily adaptation, and in many ways it can be. It's really on the back of an MR-guided adaptive trial, the phase 2 SMART trial, which is prospective trial evaluating the efficacy of basically the identical approach that I laid out, just using an MR-guided platform for daily adaptation and a prescribed an ablative 50 gray and 5 fraction dose, the same strict organ at risk approach. And the majority of patients in this trial actually had ENI very similar to what we talked about. You want to click? So the primary endpoint of that study, historically giving 50 gray and 5 fractions in the upper abdomen, especially to a pancreas tumor, was pretty fraught with toxicity risk, especially if you were using, margins for motion and not using PRV constraints. And so this trial was powered to detect a reduction in toxicity compared to historic control. And if you click, it actually did achieve that. There were 0 definitely treatment-related grade 3 toxicities observed. So the primary endpoint was met. If you go to the next slide. We similarly have open right now on a CT-guided platform, a trial that is asking a really, really similar question, the same, more or less, primary endpoint of reduction of acute grade 3 toxicity, trying to show that this can be done on a CT-guided platform safely as well, improve that global access to care, if you will, and then also has a key-powered secondary endpoint of late toxicity. Next slide. And all of these efforts have led into a just activated randomized phase 3 trial that's asking this question with an overall survival question of if we take, in this case, specifically locally advanced patients like our case, and they get lead-in chemotherapy, and then we randomize them to plus or minus dose escalated radiation using a 100 gray BED, so things like 50 and 5, hence the trial being called LAP 100. With ENI, does that improve survival compared to chemo and, low dose palliative radiation instead? So just a plug for Nina's trial, which is open and accruing. Next. So back to our case. So at 90-day follow-up, the CA19-9 at 6 weeks had gone down significantly, and by 12 weeks, it had actually normalized. The patient had a stable weight, taken her off Ozempic at that point. I think oncology clinic is one of the few places that nobody wants to see their patients losing weight. And she was doing well with no evidence of treatment-related GI toxicity. Next slide. So as one final plot twist, at 9 months follow-up, this patient's CA19-9 spiked back up to 270, and she was getting her regular interval chest, abdomen, pelvis, usually every 3 months after treatment. That showed a solitary segment 6 liver metastasis, and you can see that on the dedicated liver MRI here. So what is our plan for treatment now? Our plan for treatment is actually, go ahead, on the basis of the Extend phase 2 trial. So this was published by the MD Anderson group. It's actually a basket trial that enrolled a lot of different histologies. One of them was pancreas cancer. So that publication came out by Ludmir et al. In JCO last year. And patients with 5 or fewer lesions, although almost every pancreas patient included had just 1 to 2, could have an intact primary. They were randomized to systemic therapy with or without MDT. And they used mostly ablative dosing SBRT for that MDT. And if you click, what was shown in this trial, it had a progression-free survival primary endpoint, so a very pragmatic endpoint, was that there was an increase from 2.5 to 10.3 months of progression-free survival, which in pancreas cancer is enormous. Often when we're talking about chemotherapy regimens, adding agents may have like a 1-month survival advantage, and yet it's still done. So this is, I think, potentially a really big deal and is going to build into next trials. Okay, so next slide. So just making sure that we hammer home this really amazing difference that's shown. What is the absolute progression-free survival benefit of MDT in addition to systemic therapy for patients with oligometastatic pancreas cancer like Our Lady based on Extend? Is it 8 months? Is it 10 months, 2 months, 14 months? Okay, good. So people caught that. So the base rate was 2 months, increased to 10. The difference is 8 months, which is a big deal. So anyway, I hope that this was a helpful case to go through, and looking forward to some questions either now or at the end.
This is a great case. If anyone has a question, we have time for one.
Hi, Dr. Henke. Great
Hi, Dr.
presentation.
Sampson.
It's interesting you bring up Ozempic and the GLP-1 inhibitors, because we have noticed an uptick of that among our patients too. And we have been asking them to hold them for like a week before treatment, just because even though they were being NPO for 3 or 4 hours prior to adaptation, we were still noticing like gastric fullness, and that their dinner was still in their stomach the next morning. So yeah, just be on the lookout for that. Because it may not be something that your hospital prescribes. It's from their family practice doctor, and maybe it hasn't made it into the med rec yet. So it's something we actually screen for now, just because we were noticing it was eating into our PTV op coverage when patients continued on that medication.
That's really smart. So like Pam mentioned, excuse me, Dr. Sampson mentioned, one of the big things that we worry about in GI setup day to day is stomach filling, and patients get NPO instructions and GLP-1 inhibitors if they reduce or slow gastric emptying, or if patients just generally aren't compliant with NPO instructions, or if they have gastric outlet obstruction from their tumor kind of brewing and have a full stomach. Although you can adapt the dose away from that full stomach, if that stomach is all of a sudden completely pressed up to the whole length of your tumor, obviously, although it will still be safe with adaptation, your coverage is really going to go down the drain if you're having to peel dose off that stomach wall. So keeping an empty stomach is still important even when you can do daily adaptation.
Great. Good things to keep in mind. We're going to move onward to our head and neck coverage here.
Great. Can you hear me okay? Okay, excellent. So thank you so much for the invitation and really opportunity to be on the panel. I really enjoyed talking about head and neck adaptive, and I think this case is a good illustration of where it can be, quite useful for patients. So if we go to the next slide, this patient presented with sort of this relatively rapid sort of progression of a neck mass, then dysphagia, then odynophagia, and a hot potato voice. And if you haven't heard a hot potato voice, you will know it when you hear it, because it's a very clear kind of sound, because the patient's tongue is in the way of proper phonation. And he's a Dallas guy. I'm in Dallas, and he was in New York with his daughter, who just had his granddaughter. And the daughter was like, "What is wrong with you? Go see a doctor." So went to see the doctor, who observed all of these findings. And actually, the tumor was visible when he opened his mouth. These are some sample endoscopies. And what you see in the upper right pane is actually the base of tongue tumor coming over the soft palate. It's not involving the palate. It's just so high, so built up, that it was sort of that sort of elevated on exam. And in the bottom right, you see the deviated epiglottis, with the disease kind of going right on top into the vallecula, and really, in the end of the day, the bilateral pharyngoepiglottic folds. So past medical history is always important. And he does actually wear hearing aids, and he's had them for some time. Hearing is okay, but clearly insufficient for use without augmentation. And he did have a CABG 6 months earlier. His performance status is 0. He's running his own company and such, but he does have a cardiac history as well. So let's go to the next slide. The patient, like as I mentioned, was seen at an outside facility, underwent a PET MRI, which showed no evidence of metastatic disease. And just sort of from a teaching point, don't get PET MRIs off protocol. These are really not the standard, nor do they, frankly, have the information you need, the resolution you need for CT-based sort of anatomy and such. But you can see in these 4 panes, pretty aggressive disease. So upper left, you have a very bulky base of tongue tumor, extending in the upper right, basically to fill his vallecula and sort of the oropharyngeal space. It's always a little deceptive in terms of the patient's actually sort of airway. I mean, he was very functional, had no stridor, but when you're on your back, you can see this. So this can be a little bit deceptive, but he didn't have any airway issues. But it is a sign of really a bulky process. And you can already see on the upper right pane how he's got bilateral nodal adenopathy. On the bottom left, that not only did he have adenopathy that was sort of extending down to right level 4, but it was even involving sort of the almost the thyroid cartilage, actually. And then on the bottom right pane, this is the coronal, that sort of big exophytic mass in his sort of upper pharynx, that's his tumor. And you could also see some of the aggressive adenopathy. So the rest of his labs were within normal limits. He had full kidney function. There was no issues there. If you go to the next slide, he was biopsied P16 positive oropharynx cancer. What would you like to do? Radiotherapy with concurrent weekly cisplatin, with concurrent cetuximab, concurrent carbopaclitaxel, or accelerated radiation. All right. So very interesting. So, what are the contraindications for cisplatin? One of them is going to be, hearing problems. And it's always reasonable and appropriate to send a patient for audiology, especially when you're on the margin. And cisplatin is without a doubt the de facto standard. Really, bolus platinum is the evidence-based standard, but at this point, weekly cisplatin, at least for our recent Astro guideline, is considered acceptable. But he has bilateral hearing aids, and as such, that really is effectively a contraindication, given his degree of hearing acuity. So then the second question is, can he get any systemic? And, like I said, he was in pretty good shape, reasonably able to receive a concurrent agent. Cetuximab or carbopaclitaxel are reasonable. Cetuximab is, supported by level 1 evidence, although less than cisplatin, obviously. Carbopaclitaxel has, for better or worse, become our institutional standard for many of these cases, in part because of some retrospective data, as well as some relatively encouraging data from University of Michigan using this doublet. Accelerated radiation, if the patient's not able to receive a concurrent agent, would certainly be standard. But we ultimately chose carboplatin paclitaxel, although I think the middle two, either of those would have been tolerated by the patient. As you get to sort of the 60 to 70-year-old range, you do have to be mindful of the toxicities, especially when you have recent cardiac history. And that is one of the challenges with tux, actually, because if you get very severe mucositis, you can have a very hard time resolving that because it stays in the body for so long. Go to the next slide. So we treated this patient with reasonably standard plans. His GTVs were taken to 70 gray and 35 fractions. We do not use a CTB 70 here, so it was just GTV plus a PTB margin. There were a couple of equivocal nodal volumes that didn't seem quite sort of convincing enough to be 70 gray, but certainly valuable to treat them a little bit higher than standard. And then the primary CTV around his tumor, including the base of tongue, some of the pre-epiglottic fat, went to 56, and then his elective neck went to 52.5. This is very consistent with what was in RTOG 1016, treating essentially posterior 1B and 5 bilaterally, including the retropharyngeal nodes. For what it's worth, our standard elective neck dose here is 40 gray and 20 fractions, with then a subsequent boost to 70 gray. But based on all the nodal disease, which is kind of confluence, there really didn't seem to be a point of doing a sequential plan. So when you go to the next slide, here's my question for you. So, okay, so we're going to get ready to treat this guy. What is your technique? So either standard IMRT or VMAT without a plan for adaptation, IMRT or VMAT with adaptation, either online or offline, protons, and then with or without a plan for adaptation. All right, very interesting. Very good. All right. All right. I actually think you can justify any of these to some extent, though I strongly believe that bullet 2 is just how he was treated, will lead to the best therapeutic ratio. If you go to the next slide. So this was his treatment plan. So there's a lot of 70 gray there because he just had a lot of disease. You can see actually in the middle pane, sort of some of that mass almost invading the thyroid cartilage was pretty impressive. We were still able to get bilateral parotid sparing, as you can see in the coronals, which is satisfying, but it's just a lot of 70 gray. So if you go to the next slide, fortunately, it was a non-smoking HPV-associated patient. So you can see in the bottom left what a substantial reduction in disease he had very quickly after starting therapy. And you can see on the right side, if you just remember how filled the molecular was, like, this is great, right? So what do we do next? Go to the next slide. All right. So what do we do now? So we just stay the course. There's not high-level data saying we should adapt this guy. Let's just do it because you can't in good conscience not. Yeah. So it is in fact true, as I'll show you, there's really not good high-level evidence saying that we should do it. There's not. We'll discuss that paper in a second. But even before online platforms became available, we were always facing with this decision. Now it's a little bit easier because we can do it easier, but this has always been a question sort of in the field. So if you go to the next slide, we can't really talk about head and neck adaptation without discussing ARTIX. This was a really nicely done trial from France. It was a phase 3 study in locally advanced oropharynx cancer of weekly ART versus no ART. This was all offline. It was an intense amount of work. So they did weekly CT SIMs and then replanned, and that replan was starting no more than 5 days. They did it every week. The study was powered for 1-year measured salivary flow rates, not glow rates, although maybe they were glowing. The fact is that salivary function is thought to be the most likely to be preserved with adaptation. So I think as a primary endpoint, it seems reasonable. Go to the next slide. This is the patient population. It's really important to understand these are not our typical North American patients. If you look on the left side, many both actively smoking patients and former smoking patients. So you can understand that when you look in the middle pane that fewer than 50% of them are P16 positive. This is a recent trial. It's just sort of the natural patterns of disease across the ocean, and they're big. So if you look in the bottom there, the largest diameter of the primary was 4 centimeters. So we're almost at like a T3 level just by definition. So not exactly what we see here with small primaries and big nodes, which frankly can inform the result, right? Because a lot of times it's the nodal sort of treatments that are shrinking that may ultimately lead to improved dosimetry on the parotid glands. I think a real challenge in interpreting the study is that there were a lot of bilateral nodes, and unfortunately, there were more bilateral nodes in the replanning arm. This is an important consideration. I mean, more than a third of patients on the replanning arm had bilateral adenopathy, which is really problematic in terms of patient-reported outcomes in particular, not to mention some of the salivary output from the submandibular glands. Go to the next slide. It was a totally negative study. I mean, there was like bupkis here. From the beginning to the end, there was no difference in salivary flow. There were no difference in PROs. It doesn't mean it wasn't a great study. It was just a negative study. And I think we have to sort of reconcile this with our expectations of adaptation. There was sort of this one nuclear study that suggested that excretory function was better, but this really, I think, is clinically insignificant. And so as we try to understand, go to the next slide, please, understand what happened here. I strongly believe this is not the death knell for adaptive radiotherapy. There are a lot of things we have to consider in this study. They had the product doses were about 26, which is reasonable, but it really begs the question is how much change was there in that, how high on the gradient were these parotids? It probably was a bit of a softer gradient. You had contralateral nodes. So we don't know what the control arm actually was doing there over the course of the week. So it's hard to even know what we would expect. If we had a bit of a sharper gradient and the parotids move more medially, you might be more likely to see a delta, see a change that would have been rectified by the adaptation. I think PROs almost more than salivary flow are important in terms of how patients feel their mouths are dry. And without avoiding the submandibular glands, period, it's very difficult to sort of expect an answer from this kind of randomization. Their replans were delayed by a couple of days. But at the end of the day, this was a really nicely done study that highlights how important it is to select patients properly. There's clearly going to be a population that's not going to get a meaningful benefit. I think the key is finding those who would. So if you go to the next slide, we have a few adaptive platforms at UT Southwestern. This patient was treated on a cone beam CT based platform called Ethos, which is relevant because we have a non-adaptive unit called Halcyon, which is the same accelerator just without the adaptation. And we started our program, we wanted to have the option to adapt or not adapt for patients who are getting fractionated therapy. So we essentially start patients who are going to be adapted on an IGRT machine. And then when we want to adapt them, we call this an adapt on demand platform. So if you look in the upper pane there, that says treatment schedule, like week 2, first day, we're going to adapt. We bring them to the cone beam CT based adaptive machine, and then we do an adaptation. Then we take that adaptation and we bring it back to the IGRT machine, and we continue that until we adapt again. And so this idea of adapting on demand is kind of replicating the offline workflow, but doing it in a much more efficient way for the patient and for the physician in the department. Let's go to the next slide. So to provide some insight into how this works, I do think this kind of reflects what sort of adapt on demand does for head and neck cancer. One of my colleagues, Dr. Abigstall, published as our first experience and showed that the most salient benefit from adapting is preservation of coverage. This is clear. Why is that? Well, the system is built to preserve coverage, and it makes it cooler. So the plans are much more homogeneous, which I do believe is important, but those are the most obvious improvements, coverage and homogeneity. We did improve parotid doses, ipsilateral parotid doses, and the larynx, 3 gray here and there. Better than not having it, but I think the most obvious changes, are in coverage and heterogeneity. So when you go to the next slide, we updated our series. Oh, actually, this is important. So how much time does it take? Go to the next slide. Sorry about that. It takes about 13 to 15 minutes of fraction. So our therapists are trained to do the initial organs at risk. They call them the influencers in the system, but really they're sort of still ARs. Then the physician comes, does the adapting, and then patients treated. We're now down to a room in, room out time of about 35 minutes. Which is pretty good. When I started my career, IMRT actually took 30 minutes to deliver. So I find it very impressive that the system is fast enough to do this. You take this and compare it to an offline approach, resim, recontour, replan, et cetera. It's really kind of remarkable savings to do this on an online platform. Just go to the next slide. We updated our experience with a really wonderful medical student who might be applying to a residency near you, Julia Shi, and looked at our experience with 70 patients, almost all of whom had chemoradiation. And this kind of reflects our general experience with adapting. About a third had 1 adapt, about a third had 2 adapts, and a third had 3 adapts. And there wasn't sort of a trigger per se, like a volume change or a weight change. It was sort of more clinical judgment. But this is sort of how it is, how patients sort of need to be adapted. It's roughly sort of at this pace, about a third, a third, a third. When you go to the next slide, the results pretty much echoed what we saw in our previous experience, which makes sense. It's the same system, a lot more preservation of coverage. But I think importantly, when you go to these bottom numbers, there was preservation maybe preservation is not the right way. There was a cooling of the plant, substantially. We saved 20 cc's on average of 103. That's a lot, getting more than 103 in a patient. This is usually in a primary tumor that's T2 to T3. And in terms of conformality, we looked at the volume of tissue, just sort of raw person getting 70 gray outside of the PTV, it was about 10 cc's different, which this is not nothing in a patient, especially in a young patient who may deal with the heterogeneities for life. If you go to the next slide, this is sort of one question: is how many times do you need to adapt? Once, twice, 3 times every day? I don't know what I was hoping the answer would be, but what we found is that every time you adapt, you get something better. So of the 20 or so patients who had 3 adaptations, we applied the first plan to the third adaptation and the second plan to the third adaptation to see whether or not they would kind of converge after the first one. And in fact, they didn't. So the more we did, the better the plans were. And even just from like a volume wise, if you compare the first ART plan with the third, there was still like 20 cc difference roughly in how much 103 there was. So it's a bigger conversation of how often we should adapt, but it's relevant that if you think you're going to benefit from a big change in PTVs and such, you may do it. There's no sort of threshold at which point additional adaptation is not going to help you. Go to the next slide. As before in our previous experience, and frankly, to some extent, what we saw in the Arctic study, there wasn't a clinically meaningful improvement in any of the OARs, whether it's the salivary OARs or the dysphagia OARs. Some nominal improvements that were statistically significant, but nothing where I would say there's a living and dying, a swallowing or not swallowing kind of threshold. We did find that their PTV change was a predictor, but it wasn't particularly strong such that we could use it as a trigger in the future. So the more relative PTV change, I forget the threshold, 10, 15%, they're more likely to get an improvement in coverage and parotid dosing. Go to the next slide. So I'm going to kind of breeze through this, except to say that, you're only going to get what you optimize for. So if you don't change your optimization, you're not going to be able to get a much better plan, right? You'll be able to preserve the plan you had, which is still better than going forward with a plan that might be too hot or, overdosing in some areas, but you're not going to get a markedly better plan, right? Because you're still using the optimization from X number of days ago. If you go to the next slide. And so actually, we'll just because time is tight, go to the next slide. This patient, I talked a little bit slower than I expected. So what I'll say is that we tried the exact same study in post-op, and if you go to the next slide, it didn't do very much. So things are too static, right? There's no target to that shrinking. The patients, generally, their weight is stable. They've lost a lot of weight from the surgery. And so from a coverage perspective, there was numerical improvements, in this case, weekly adaptation, but these improvements were, again, kind of modest. And if you go to the next slide, the OARs were almost uniformly stable. Again, like the spinal cord dose, which is never really an issue, was a little bit cooler with the adaptation. So our department practice is not to adapt in port cases because you just don't get sort of the juice for the squeeze. Go to the next slide. And go to the slide after that, please. So this patient had a marked improvement in his disease over just a 2 to 3 week period. As you can see with the MR sim we brought into the ethos system to help with contouring. And if you go to the next slide, I sort of begged my physicist, and I actually did have to beg because it isn't part of the system, to add a structure and then change it from the original sim to the adaptation in the constrictors. And so you can see on the right, had we not done an adaptation, all of the constrictors would have gotten 50 to 60 gray. The upper pane is 50 gray. All of them would have. By adapting on the upper left, by turning on that new OAR, it dropped down substantially, which, go to the right bottom pane, that's 60 gray. Go to the left side, that's all being spared 60 gray. So this is a really important improvement, I think, for the patient's OARs. As I mentioned, if you go to the next slide, OARs don't often change that much, but his did, and that's why selection is so important. So this guy had 4 adaptive fractions. He did lose like 20 pounds and was somewhat resistant to it too, but in the end, he didn't need it. He's now 2 years post-treatment. He's NED. He's back working full time. He's had a very sort of nice convalescence after, a difficult, as you imagine, chemo radiotherapy course. So I think that's the last slide. Maybe there's one more slide, but the future is really to do this dynamic optimization because it's critical to be able to get a best possible plan, not just to go to your original plan, especially as you have anatomy changes that would make certain OARs more achievable, swallowing organs at risk, sometimes the parotid, things like this. So I know I'm out of time here, so I don't want to keep on going, but these are the key issues in head and neck. I think it's a wonderful disease site to adapt in. It is, just different. And that's why it's important to have different disease sites because you may be more stereo and GI and more even conventional with head and neck. So a lot of options, and I think you'll hear more about these in the years to come.
Great, thank you. I think we'll keep on moving for now, and then if we have time at the end, we'll get any questions for any of the cases. So we'll move right along to our last discussion.
Hi, thanks for the invitation. I'm happy to talk about this topic today. I'm Pamela Sampson. I'm a thoracic radiation oncologist at WashU in St. Louis. And I'll be talking about some applications of thoracic adaptive radiation therapy. Next slide. Yeah. So our initial presentation here is a 61-year-old woman with a distant history of an early stage lung cancer of the right upper lobe back in 2018, status post-lobectomy. And in her follow-up imaging, 2024 was found to have an interval increase in a right middle lobe lung nodule. So that's why it's so high up, because she had a right upper lobectomy previously. So middle lobe shifted up. She quit in 2018 when she was diagnosed with her first lung cancer. She has mild dyspnea on exertion. PFTs had a FEV1% predicted of 70 and a DLCO percent predicted of 57%. Next slide. PET scan was done, and basically this showed FDG avidity of the lesion. The SUV was 13.6, but no suspicious or enlarged lymph nodes, no avid lymph nodes, and no evidence of metastatic disease. Okay, next slide. So this presents a clinical problem because obviously this is close to what we consider a mediastinal organ at risk and would be classified as a central tumor. And early stage central and ultracentral tumors have many clinical challenges that we have to address. So these patients often are not surgical candidates, especially when they're near the proximal airway or involving the carina. Even if it's early stage, because of its location, it may actually require bilobectomy or pneumonectomy. And most surgeons are not willing to do that for an early stage lung cancer. However, because of the reported high historical rates of grade 3, grade 4, and grade 5 death toxicity from using a conventional SBRT scheme for central and ultracentral lung cancer, the traditional approach has been to fractionate those treatments additionally. So 60 gray in 8 fractions, 60 gray in 10, 60 gray in 12, for example. And even then, you can still have some significant rates of toxicity that are listed here in this table. We also know that as you get to 10 and 12 fractions, our BED goes below 100, which is critical for local control. And even when you split out squamous cell carcinoma from adenocarcinoma of the lung, it's even more important we get the highest BED possible for squamous cell carcinomas. So we really lose our effect on local control when we slip below that number. And then the higher rates of toxicity I mentioned before. Next slide. And this is what that type of toxicity can look like. So typically we define ultracentral as a GTV that is touching a organ at risk in the mediastinum, whereas a central tumor is within 2 cm of that organ at risk. And this is exactly the type of complication we can have here. So what's shown is some endobronchial necrosis. And what we worry about are fistulas in this location between things that shouldn't be connected. So either a bronchovascular fistula, which can cause life-threatening hemoptysis, or bronchoesophageal fistulas, which can cause recurrent pneumonias, weight loss, and sepsis. Okay, next slide. So ideally, what we would love to be able to offer these patients is the same quality SBRT that we offer, that we give for peripheral lung cancers, 55 gray and 5 fractions at our institution. And what we would need in order to do that is excellent image guidance to be able to really see with high resolution those mediastinal structures. Very careful motion management. These are still moving targets, and the ability to adapt for day-to-day setup changes or any tumor growth from the time of simulation. Next slide. And so to investigate this further, if adaptive radiotherapy would have any potential benefit for delivering a definitive intent SBRT to this patient population in a conventional manner, we started a clinical trial. This was a phase 1 trial of CT-guided SBRT or CT star for the treatment of central and ultracentral early stage non-small cell lung cancers. And this protocol was actually written mainly by one of our residents, Joshua Schiff, who's now an attending at USC. No, City of Hope. I know it's in LA. City of Hope. Lauren, you might need to correct me. It is USC. My apologies.
USC.
I was right the first time. I apologize. Okay, next slide. So our primary endpoint for this trial was the rate of grade 3 or greater toxicity at 12 months. And our exploratory endpoints are the rate of high-grade toxicity at 24 and 36 months, because it should be noted that when treating SBRT to these ultracentral central lesions, the toxicity can appear very late. So unlike radiation pneumonitis, where once you get past that 16, 18-month point, you think, phew, okay, we're out of the window for radiation pneumonitis. Like, you typically don't see it past that. These type of toxicities can appear at 2 years, 3 years, even 4 years out from treatment. So we are going to do long-term follow-up on these patients. Obviously, the local control rates at 12, 24, and 36 months, progression-free survival, patient-reported outcomes, which I think is, should be a part of any type of radiotherapy trial we do nowadays. And then dosimetric analysis for patients with and without treatment-related toxicity, with and without recurrence. So our hypothesis is that CT star will result in either similar or reduced rates of grade 3 toxicity compared to historic controls of 20%. Okay, next slide. So the eligibility criteria for this trial is that they have an early stage central or ultracentral lung cancer, that it is within 1 cm or touching any of those mediastinal structures, and importantly, that adequate tumor coverage can be achieved. And we define this as greater than 98% of the GTV receiving greater than 90% of the prescription. If we simulate the patient, they've agreed to the study, they've consented to the study, and we plan them, and they're falling below this metric, we actually consider them a screen failure and treat them conventionally, whether with 12 or 10 fractions. Because what you do not want to sacrifice on adaptive coverage, and I think all of us on this panel would agree to this, no matter the disease site, is you don't want to run areas cold. Okay, you don't want to have a low dose within your tumor. So we also had patients that had to be able to hold their breath for 10 seconds, because for this we are treating with exhale breath hold and an ECOG of 0 to 2. Next slide. So this is an example of what her plan looked like. So this was done on Ethos using hypersight imaging, and this is a 2-arc plan. And these are the constraints we listed here. So these are pretty traditional SBRT constraints, like you would for any 55 and 5 plan. Initially, we allowed a PTV max of for the target of up to 130% prescription dose. But based on the Sunset trial, when that came out and showed good data at 60 and 8, we noticed that their Dmax was 120%, and they had a good safety profile. So we made an amendment to lower it to that dose. Okay, next slide. This is basically how our physicists and dosimetrists plan the treatment. So what you'll see here is we have drawn out the esophagus, we've drawn out the trachea, and we've drawn out the great vessels. And we use that as basically a composite OAR to help optimize the treatment. And what you can see here is the 55 gray, the 4950 gray isodose lines really bending to carve out from that great vessel aggressively. And I will say, you know, now in the age of auto contouring, it is helpful. It is a time saver, but there are certain anatomic structures that auto contouring still struggles with. And by and large, great vessels is one of them. So I'm always very, very closely evaluating the auto contouring of the esophagus, of the trachea, and of the great vessels, because your treatment plan is only going to be as good as your OAR contours, because the optimizer is working off those. Okay, next slide. So this was the hypersite imaging. So this is going to be fraction 1 for this patient at the machine. And when I'm drawing out her OARs or checking the auto contours on the organs at risk, I use the abdominal windows for that, so I can evaluate the mediastinum. And what you see here is that even without contrast, it delineates those structures quite well. And then I flip to the lung windows on hypersite to make sure that the tumor is being adequately covered as well, because sometimes you can have a small amount of growth in between the time of CT simulation and the first treatment. So I make sure to look at both the target and the organs at risk on both pairs of windows. Next slide. All right, so this is the kind of report I would be getting once we have done we've contoured the daily anatomy, we have re-optimized the plan. Ethos or CT guided adaptive radiotherapy is going to let me know my reference plan, my scheduled plan. So my reference plan was my original plan. My scheduled plan is if the reference plan was applied to today's anatomy, and what the adapted plan, what the re-optimized plan would give me, what benefit it would give me. And what I saw here is that there would be a meaningful increase in target coverage. It did not violate any organs at risk, and that's pretty typical for lung. What we've been noticing in lung as compared to abdomen is that usually the benefit of adaptive is that we can get better coverage with adaptation. It's not so much that the great vessels are moving or the esophagus is moving that much like GI organs can. It's basically that we can do subtle redirection and reoptimization to cover our target even better than the original plan. So this plan was selected for adaptation. Next slide. This is how we communicate to each other. So, you know, we're in a practice where there's a different adaptive physician of the day covering everything from thoracic to GI to GU to gyne. So when we walk up to the machine, we want to know what we're treating and why, and what the treatment the day before looked like. So I give my attestation that we did the adaptive treatment. The physicist puts a note of what contours were edited, why we adapted. So here, PTV opt coverage was improved. And then any notes, any tweaks we had to do to the plan to make it run smoothly. So this is our daily documentation that we do for each fraction. All right, next slide. So this was a patient that was also on the CT STAR trial, and you may think, well, what the heck? How is this central? It's at the periphery of the lung over by the chest wall. So what this was a patient who had had a prior esophagectomy. She did not have she had an upfront esophagectomy, did not require any radiation therapy, but her gastric conduit, this is typically what they look like, how they settle out in the chest, and her esophagectomy had been years ago. So we determined that, yes, we would call this ultracentral by proximity to her gastric conduit. So she was consented for the trial, and we did, because it was so far posterior, we actually did like some quarter arcs. Next slide. And this was the on-table hypersite imaging. Again, I'm always flipping between the lung windows to make sure my target is adequately covered, as well as the mediastinal windows to make sure my OARs are covered or appropriately contoured. Next slide. And what we saw here is that for each of her fractions, the stomach would have broken our dose constraint. So, so every single day for each of her 5 fractions, we did select the adapted plan. So again, reference plan, then scheduled plan, then the adapted plan is at the very end. And you can see with reoptimization, it was always able to resolve our dose constraint on the stomach. Okay, next slide. So what are some other indications for adaptive radiation therapy? So one that I am increasingly using and taking advantage of is offline adaptation for tumor shrinkage and lung re-expansion. I'm sure you guys have all had those cases where either it's a well-responding non-small cell lung cancer, or it's a limited stage small cell where there's lobar collapse and pneumonia. And after 10 or 15 treatments, things start opening up and the tumor starts shrinking. And if you continue to apply that plan, your V20 estimate kind of goes out the window. So for those patients, especially in the age where they're getting adjuvant immunotherapy and they're at increased risk of late pneumonitis, we want to make sure we're keeping our dose to the lung always as minimal as possible. So this was just a very a great example that was published in Advances back in 2023 of what that can look like as those airways start to re-expand. So that's one I'm increasingly using. Next slide. Another is direct-to-unit therapy, or what was previously called simulation-free treatment. So here in Missouri, as well as I'm sure other programs, you get patients that drive 3, 4, 5 hours for their treatment. And we're looking for ways to expedite their treatment. So this is a very fancy version of sim and treat, but for lung SBRT. So this was a single fraction lung SBRT, either for definitive intent, which we know is safe and effective based on RTOG data from Videtic, as well as for single fraction oligometastatic disease. So in this situation, we pre-screened our clinics for patients that live far away. We planned their treatment on their diagnostic chest CT, and then we planned on that, approved that plan, and then adapted the treatment plan on the patient's hypersite cone beam CT on ethos, because adaptive has to overcome a lot of things from that diagnostic CT. Arm position is the biggest one, because you can see here our arms were down in the diagnostic scan, and in our ethos machine, the arms are up. The curved couch going from a curved couch to a straight couch, and those are typically the biggest. Also, any growth, because sometimes I'm seeing these patients as a second opinion, and their CT was 2 months ago, their PET was 2 months ago, and the tumor may have grown since then. So what we saw in this trial was it was very well accepted by patients. And we've all had those consults where patients were like, I thought I was getting my treatment today. This way you can actually offer that to them. It was amazing to me. This trial had a 100% acceptance rate. Not a single patient we offered this to passed on it. So I think there is a very significant patient appetite and interest for these expedited treatments. For oligomets, the med-oncs love it because it helps decrease the time that they can go back on their systemic therapy or go to next line therapy. Next slide. And then finally, one we've just started working on as well. At WashU, we have been doing cardiac SBRT for over 7 years now for the treatment of refractory ventricular tachycardia. Previously, it was called cardiac SBRT. In the cardiology community, they refer to us and our treatment as non-invasive cardiac radioablation. Whatever you call it, we're looking at adaptive models of that too, because what can sometimes happen is the left ventricle sits right on the diaphragm, and often you can have these targets for VT that are at the apex of the heart. they label the left ventricular anatomy kind of like prostate. Apex is the bottom and the base is the top. And whenever we have those, the stomach becomes very important. So whenever we have a target that's down towards the bottom of the heart, we will ask patients to be NPO. We will ask them if they're on a GLP-1 to hold it for 1 to 2 weeks before. Sometimes we will do inhale breath hold for these treatments to try to get more room. But an additional thing we're looking at is adaptive radiotherapy. And this was just an example where if we had done an adapted plan for this patient, it was just meeting the constraint of 22 gray, just barely though. If we had used adaptation for that, it would have lowered that stomach dose by a significant amount. And I say that because there have been 2 reported cases of gastropericardial fistula with cardiac SBRT for targets that were in this location. And it is just as nasty and horrible as it sounds. Fortunately, both of those patients lived. One was at our institution, another was in the Czech Republic. And since that time, we have lowered our stomach constraint significantly for single fraction cardiac SBRT. But again, it just pushes on us even hard to carve out the stomach dose when we put a lower constraint on it. So adaptive with reoptimization to meet that constraint really could help us make sure we're not sacrificing target coverage on a scheduled plan. All right, I think that was my last slide, and I don't want to go over. Just thank you to the team that has built and maintained our program. All right, thank you.
Great. Thank you, everybody, so much. I just have one quick question. Do we have any, I think with these machines, there is concern about you lack some sick stuff. Is that right? And what kind of things do you keep in mind because of that limitation?
I'll take that one on. So with CT guided adaptive and the current existing versions of MR-Linac, and I will say current existing version of CT guided with a ring gantry as well, that has FDA clearance, they're all do not have mobile couch, so you don't get that 6-stop setup. One thing that's unique about the CT guided platform, if you will, is that actually when you're doing adaptive, not for non-adaptive treatments, that's still a limitation, but for adaptive, you can actually rotate the target when you line the patient up as the first part of adaptive. So it actually creates more degrees of freedom than a 6-stop couch when you're doing adaptive. You can actually like spin it 360. Not that you would necessarily, maybe that would work for a peripheral lung tumor PAM. They're just round dots, right? But that actually creates a ton of flexibility. And then of course, anytime you're adapting a plan, in theory, if there's a patient like physical body rotation issue, you're adapting the plan so you can adjust your target accordingly. So it's something to be aware of and keep mindful of. But I think in the context of adaptive, it's a little less of a limitation than it would seem to be.
Okay, thank you. And then quickly, Dr. Scher as well. Yeah.
I was going to completely agree, but also say that what you lose, you don't get non-coplanar beams. So because you're adapting and recontouring everything, the 6D becomes far less of an issue, as Dr. Henke mentioned, but you do lose additional degrees of freedom. So, for head and neck, for example, sinus cases, certain stereotactic cases in the head and neck, you can get a very nice plan, better plan with non-coplanar radiotherapy, which you cannot get right now with these ring gantry systems. So you do lose a little bit, but it's more in terms of the beam arrangements as opposed to the setup.
Okay, great. Thank you all so much. I'd like to say we've got our next session in December, so a little bit of a break